Hello guys, am I audible and visible? If so, say a hi, hello. Can you see me? Can you hear me? I think the previous one got cut, disconnected. I don't know why. Okay, student. Thank you. So, good evening, Mohan. Good evening, everyone. So, we'll be starting with the same renal pathology FARRE. So, yesterday we had discussed about nephrotic syndrome, and also we saw about cystic kidney disease, right? So, we'll be continuing the rest of it. We'll be starting with hypertension and diabetes. Hello, Savant. Hello. Hope you're doing good. We'll look at hypertension and kidney, and also we'll look at few classical glomerulosclerosis which can come in an exam. And then we'll also continue with the genital system. We'll talk about cervical cancer, which I think I missed in the live classes. I'll cover cervical cancer, which might very important question for university exam. Little bit about endometriosis and ovarian testicular tumors, and few things with the breast parenchyma disorder as well. Fine. So good evening, Padmavati. Good evening. I hope everyone is doing good. Fine. So let's start with hypertension and kidney. See, when you take hypertension and diabetes, these are the two common disorders which can cause renal pathology when you come to a clinical practice. The minimal chin disease, PSGN, FSGS, RPGN are a bit rare compared to all of these disorders. Hypertension diabetes still is the leading cause of renal failure in our country now and also will be in the future because the volume of hypertension and diabetes is way more than any of the glomerulonephritis you've read, right? So when you take hypertension, we divide hypertension into two common things. How a question can come with hypertension is they can give a simple scenario of old patient with hypertension being hypertensive for 10 years together or 20 years together, or a very severe malignant hypertension. What will be the postmortem appearance of the kidney? That could be the question asked here, right? So we divide hypertension into a benign hypertension and malignant hypertension. For all of you guys who are online, can anyone tell me when do you call a hypertension malignant? Like yesterday, let's make it as much interactive as possible. When do you think you can call a hypertension malignant? You will call a hypertension malignant when the BP, the systolic BP, is in the range of 190 or 200 millimeter of mercury, right? So when you have a blood pressure, systolic blood pressure in the range of 190 to 200 millimeter of mercury with an end organ damage, the hypertensive emergency or urgency, I call it a malignant hypertension. On the other hand, I call something as benign hypertension if it's hypertensive, not a very severe hypertension. Any person who's chronic hypertension, BP, I'm just assuming the range of 130, 140. I'm going to call it a benign hypertension, right? Both these hypertensions can definitely affect the kidney and it affects in a different way. To understand the vascular disorders of kidney, this comes under the vascular disorders of kidney, we have to understand a little bit more in related to hypertension, right? So we have a type of vessel called as an arteriole. Can anyone name what is the other name of arteriole? They're also called as resistance vessels, right? Perfect. Okay, they're also called resistance vessels. Arteriole definitely called as resistance vessels or resistant capillaries. Just give me a second. Fine, they are also called as resistant vessels or resistant capillaries. Okay. So when I have something called resistant vessels, these are the ones which will be predominantly affected in case of hypertension because they are resistance, right? They are the one which is going to provide the total peripheral resistance and they'll be the one which will be maximum affected with hypertension, right? So if we take that, let's see what will happen to a benign hypertension and then we'll see what will happen to a malignant hypertension. The benign hypertensive changes in the kidney are termed as benign nephrosclerosis. You can have a 3-mark question just asking what does a benign nephrosclerosis means, right? Okay. Just tell me, hypertension or the BP is an outward force or any inward force? Any blood pressure for our body is an outward force, right? It's just an outward force. So let's assume there's a tiny arteriole and there's an elevated BP in any of the patients. Can I say it is going to kind of push the fluid outside? It's an outward force. So any outward force, you won't end up in having edema because auto-regulation will happen for sure. But this outward force, can I say that the proteins, the plasma proteins can get deposited on the wall of the vessel? Hello Yashpal. There's a possibility, right? This outward force will result in the plasma protein deposition, okay, on the wall of the vessel. That will get deposited definitely in the wall, right? In other words, over the period of years, I'll have a blood vessel which will be deposited with lots and lots of proteins. Okay, if you look at the wall of the blood vessel, it will have lots and lots of proteins. So in other words, the blood vessel is going to look like this. I'll have a tiny blood vessel with the lumen narrowed because the wall is having lots and lots and lots and lots of protein deposition. This is what's happening in this microscopy. I'm having a protein deposition. What is the color of protein in the biopsy? You can see the color there, or you can definitely tell me with your knowledge, existing knowledge, protein's color is going to be pink, right? As simple as that. Even in this image, you have a protein which is completely pink in color, right? It's a pink color protein. So I'm going to give a term to this. It's a pink color deposit composed of lots and lots of protein together. So we call them a hyalin. So hyalin, and the artery involved is arteriole. So we call it arteriolo and sclerosis. Okay. This is a microscopic finding of a benign hypertension and hyalin arteriolosclerosis, a very, very classical finding. It can definitely come to a 2-mark question for you for sure, right? The hypertensive or vascular changes which happens in the kidney with response to hypertension. Because of this hyalin arteriolosclerosis, even you can look at the biopsy finding here, or you can look at the thing what we drew. What's happening to the lumen size? Anyone who's online, can you comment? What's happening to the lumen size here? They're becoming smaller, they're becoming bigger. Definitely the lumen is becoming smaller, right? Since the lumen is becoming smaller, or it's becoming stenotic, right? When there's a reduced lumen, will there be tissue death in the area where the arteriole is supplying? Yes, obviously. Because of the reduced lumen, you will have cortical destruction. The renal cortex, right? There will be cortical atrophy, or cortical tissue will be destroyed. Perfect. Okay. So they have this cortical tissue destruction. The surface of the kidney. Normally, you must have seen the surface of the kidney. Normally, surface of the kidney will be smooth or it will be irregular. It will be very, very smooth, right? Because of this destruction, do you think it will become irregular? Yes, it will become irregular. It will become like this. Can you look at this kidney? Can I say for sure the outer surface of the kidney here is not smooth? It's very, very irregular. We call this a granular contracted kidney. Okay, this is also very important. Even if it's not going to come in a university exam for you, you must have had specimens of granular contracted kidney in your pathology lab. It can come in the viva. When you have a granularity and it's a smaller kidney, we call it granular contracted kidney. One of the major causes hypertension. Just for your differential diagnosis, one more cause, it can also be seen in chronic glomerulonephritis. Even in case of chronic glomerulonephritis, you will have a granular contracted kidney. That's how a granular contracted kidney looks like in gross and in microscopy. The reason for the granular contracted kidney is you can see that you are having hyalin arteriolosclerosis, right? That's what happens in a benign hypertension. Now let's go to malignant hypertension. Like I said, what does malignant hypertension mean? Or I can use the term malignant nephrosclerosis. Malignant hypertension, the BP is in the range of 190 to 200 millimeter of mercury. So do you think the arteriole will be staying the same or it will rupture? Definitely, right? It's a very, very high BP in the range of 190 to 200 millimeter of mercury. Definitely there is a chance that the arteriole can rupture. This rupture of the vessel results in two findings. Whenever an arteriole rupture, you will have petechial hemorrhages on the surface. If you have a skin arteriole, it's rupturing, you will have petechiae on the surface of the skin, right? The same thing can happen on the kidney surface. We call it flea-bitten kidney. Okay, it's called a flea-bitten kidney. The petechial surface is on the surface of the kidney. I'll just zoom this here for your understanding. I'm sure it's clear, right? You can see tiny, tiny, tiny red dots which are petechial surfaces. Nothing but rupture of the arterioles due to the excessively high blood pressure. Fine. So now let's say my arterioles are rupturing. Can my body leave it like that, or it should adapt? Any stressful stimuli in the body, adaptation is must, right? So these vessels are rupturing. They are not able to hold the blood pressure. What is the only way you can adapt? You guys are going to tell me it will become thicker or thinner. Because you guys are going to tell me what will happen in this microscopy. Even if you don't know, it's completely fine. You can easily evolve to it. It should become thicker, right? Obviously, it should become thicker. I'm having 3 layers in a blood vessel wall. I'm having intima, media, and adventitia, right? It should become thicker, right, Barnack? Only when it becomes thicker, I'll be able to hold the blood pressure, right? I have intima, media, and adventitia. Of these 3 layers, which you think can become thicker? Intima cannot grow. Adventitia is nothing. The only way is media, right? So what happens here is, in order to prevent this rupture, there is an adaptation. I need to prevent the rupture, so there is an adaptation. There is increase in the smooth muscle layers. Smooth muscle is going to be in the media, right? There's going to be increase in the smooth muscle layering. Because of this increased smooth muscle layering, the vessel which was like this now has become like this. It's more layers of smooth muscle, it becomes thicker. That's what you're seeing in this microscope. I hope you can easily relate that. That's called as hyperplastic arteriolosclerosis. This is also MCQ finding. You can have them in MCQ or in a Viva question or in a 3 mark in your university exam. Fine. It's a hyperplastic arteriolosclerosis, or you call it an onion skinning appearance, right? It's hyperplastic arteriolosclerosis. So one was hyaline arteriolosclerosis, the other one is hyperplastic arteriolosclerosis. Both of them are vascular change which happens in kidney secondary to hypertension, right? Both hypertension related kidney disorder can come as a 5 mark question. Like I said, they can give you a clinical scenario, a chronic hypertensive having a renal failure, what will be the changes which will happen in the kidney? Or a person coming with a headache with a BP of 120 millimeter per mercury, the patient dies. Post-mortem, what will you find in the kidney? That both can be asked, both benign and malignant hypertension can be asked in the exam. Fine, next one. Okay, next, I'm going to go to complications of glomerulonephritis. Can anyone give any examples of glomerulonephritis you know, apart from your RPG and FSGs? Anyone? Any example? Whatever comes to mind, can you give any example? You must have definitely heard about your PSGN, minimal change disease, your lupus nephritis, membranous glomerulonephritis, Goodpasture syndrome, right? Whatever glomerulonephritis you know, these both are complications. I'm just going to write a few of them. Okay. Yes, Barnak, I do have common cold, unfortunately. Right? You have PSGN, you have minimal chain disease, or any of the glomerulonephritis. Okay, I'm just writing any glomerulonephritis for that matter. There is a possibility this can have an acute exacerbation. At the same time, it can have a chronicity. Okay, both of them can happen. This chronicity is your FSGS, focal segmental glomerulosclerosis, and this acute exacerbation, I'm going to call it an RPGN. Fine. What is glomerulus? It's a very basic question, but I want everyone who is online here to answer. It might be right, it might be wrong, ignore that. What do you mean? What is the glomerulus? Glomerulus is nothing but a tuft of capillaries. That's all, right? It's just a tuft of capillaries. So what do you think the worst can happen to a glomerulus? Good evening, Sajid. What do you think the worst can happen to a capillary? Maximum it can undergo rupture. That's all, right? Capillary, the worst thing that can happen for capillary, it will get ruptured. That's what happens in RPG. If the capillary undergoes rupture, it's all of a sudden very rapid. We call it rapidly progressive glomerulonephritis. On the other hand, it's chronicity. We know the hallmark of chronic inflammation. We'll never forget that. It's fibrosis. That's all. If the entire tuft of capillary becomes fibrosed, I call it FSGS. That's a chronic disorder, right? Now let's understand what will happen to RPGN from the same basic point that if it's an acute damage, the worst thing which can happen to a capillary is it will have a capillary rupture. Fine? Perfect, Sajid. So the mechanism of RPGN is nothing but the capillary is undergoing rupture. If the capillary ruptures, or leave glomerulus anywhere in the body, if the capillary ruptures, will they have a clot formation? Obviously clot will form. Every clot is made of fibrin. So this fibrin clot, if it ruptures the glomerulus, it goes to your Bowman space. It will irritate the Bowman space and it will cause hyperplasia of few cells lining the Bowmans. What are the cells which lines the Bowmans? We call them parietal and visceral epithelium, right? So the parietal epithelium, the visceral epithelium undergoes hyperplasia. There will be a little bit increase in the WBC because the rupture of membrane is there, the rupture of capillary is there, and also I'll end up in having your clot, the fibrin. So this is going to occupy in the Bowman space. Normally Bowman space will be pretty neat. Here the Bowman space will not be neat. So what will happen is I have a capillary like this with all these cells coming into the Bowman's area. It will proliferate from here, come into the Bowman's area. Fine. If it comes into the Bowman's area, can I say it will kind of compress my glomerulus? It's coming from up and pressing it, it will compress the glomerulus. If it compresses the glomerulus, will the glomerulus function? Will it filter? It won't filter. Ends up having an acute renal damage. That's what RPGN pathogenesis is. And this thing which grows in a microscope looks like a crescent. So you can have in a Viva question, what is a crescent, right? What is a crescent? The crescent is nothing but a collection of your hyperplastic parental epithelial cells, visceral epithelial cells, WBC and fibrils. The crescent is going to look like this in your microscope. I hope I have the images. Yeah, there's an image from Robbins. You have crescent here. You have one crescent on the top and one crescent on the bottom. So the crescent is just going to compress and destroy it. And this what is the electron microscopic finding of RPGN, the rupture of the membrane. The rupture of the capillary is where everything started with, results in formation of the crescent, it compresses and causes RPGN. Fine. So first you write the pathogenesis. Here my etiology can be anything. Like I said, any glomerulonephritis here can cause this. So how do I know what is the cause? I need a classification, right? So we classify crescent or we classify RPGN based on one simple thing. It's always classified based on immunofluorescence. So I have three types of RPGN. Type 1, where I have a linear immunofluorescence. Can anyone comment which disease can have linear immunofluorescence? Type 2 is granular immunofluorescence. Linear is only one disease, which is Goodpasture syndrome, right? The Goodpasture syndrome is the only one which is linear immunofluorescence. Rest everything in your microscopy is granular immunofluorescence. You can write PSGN. It can be any other glomerulonephritis, right? It can be PSGN. It can be a membranous glomerulonephritis. It can be a MPGN type 1, type 2. It can be lupus. It can be IgA nephropathy, right? Anything except from your Goodpasture syndrome, all the glomerulonephritis you know will come under type 2, right? Type 3 is also called as a pauci-immune. So pauci-immune glomerulonephritis, there is no immunofluorescence. Actually, it's not primarily a kidney disease. Pauci-immune glomerulonephritis is primarily a vascular pathogenesis. Can anyone tell me or name any small vessel vasculitis which comes to your mind? I am sure I must have read about vasculitis. We did read about vasculitis. Any small vessel vasculitis which comes to your mind? Any small vessel vasculitis? Vaginous, right? Vaginous is small vessel vasculitis. Vaginous can cause this, right? So vaginous granulomatosis. Tachyiasis is small. It's not a small vessel, right? Tachyiasis is a large vasculitis, right? Okay. So vaginous and your microscopic polyangiitis. So these are two small vessel vasculitis which can result in a rupture of the small vessel, that is a glomerulus, which can also result in the same pathogenesis that cause RPGN. But these both of them will not have immunofluorescence. That's why it's negative or pauci-immune. So we classify the RPGN based on IF. So I know the etiology, I know the pathogenesis, I know the classification. So how will the patient present? So the presentation is where you can have a clinical scenario in your university exam. A patient, a random history, any age group, a known case of PhD or whatever it is, there will be a very sudden progression. That's very important. When you say sudden, it should be less than 24 hours. A sudden progression from a creatinine of, I'm just giving you arbitrary values of creatinine. Creatinine of let's say 1.5 milligram percentage, it becomes to creatinine of like 5 milligram percentage. If I have this sudden progression within a day, I have to suspect RPGN. That's the diagnostic point. You might have edema, might not have edema because a very fast onset, very rapid onset. They might end up in having uremic encephalitis, uremia related symptoms as well. Can have uremic pericarditis if untreated. Can end up in uremic encephalitis again if untreated. Fine. The best thing here is it will be a very rapid onset. It will have. See, then blood creatinine ratio will automatically be altered, but one thing which I can easily comment on it is creatinine. If creatinine has such a huge rise, because blood creatinine ratio can easily get altered even with subtle dehydration, creatinine won't. That's why I'm going to depend more on creatinine value. Very high spike of creatinine value with uremia related symptoms, I think of an RPGN process, fine, okay. But then proteinuria, see, I told all these diseases were existing glomerulonephritis which became RPGN. So proteinuria, hematuria can be already a part. It will not differentiate from the existing glomerulonephritis. That's the main difference here is this. If you have any progression, that's why we call it RPGN, rapidly progressive glomerulonephritis. That's the clue here. And the best way to treat, if you want to write treatment, the emergency treatment should be hemodialysis. It should be an emergency hemodialysis just to tide over the crisis. If the patient comes back to normal later on, then we will treat the primary disease. First, give an emergency hemodialysis, make the creatinine come back to normal, make all the uremic symptoms disappear, then go and maybe treat Goodpasture or PHN or whatever is the cause of that, fine. Okay, that's about your RPG. Now let's go to the second complication, which is FSGS. FSGS, we already saw, is the most common cause of your nephrotic syndrome in adults. Okay. FSGS is the most common cause of any CKD. It's not just glomerulonephritis. Even if diabetes causes CKD, microscopy will be sclerosis only. Because it's chronicity, right? Any chronic kidney disease in microscopy will end up in having FSGS, right? So in FSGS, I divide the etiology of FSGS into, hello Azia, two broader one, primary FSGS, and we call it secondary FSGS. Secondary FSGS can happen secondary to any glomerulonephritis. Whatever we saw at the start, any of them can result in secondary FSGS. Your diabetic kidney can end up in having secondary FSGS. Hypertension can end up in having secondary FSGS. So all these are primarily some other disorder can progress to it, right? Hi Bhupendra Jaiswal, good evening, right? That's your secondary FSGS. Now let's go and slightly look at primary FSGS. So primary FSGS, we kind of give one more term for primary FSGS. We also call them as congenital nephrotic syndrome. Because it said that these primary FSGS are mostly syndromic disease. It's mostly mutation related disease. It happens in children, right? It's going to happen in children. So I'm just going to give you a question. I want you guys to answer. If you have a question which says, okay, Bhupendra, Robbins is more than enough for university exam, right? Okay. If your question says that it's a child with nephrotic syndrome, what will be your first diagnosis? A child with nephrotic syndrome, your first diagnosis. You think of minimal chain disease, right? So this also is a child. They also present nephrotic syndrome. How do you treat minimal chain disease? Anyone? The treatment for minimal chain disease is very, very simple. You give steroids. Do you think steroids will work in these syndromes? Like I said, these syndromes are due to mutations. Do you think steroids will work? They don't work, right? Steroids don't work in patients with congenital FSGS. So these are also called as, it's one subtype of steroid resistant nephrotic syndrome, right? Because whenever I see a child with a nephrotic syndrome, I will be thinking of renal disease and I'll give steroids. But here they don't work, so we call it as steroid resistant nephrotic syndrome. That's one part. So now let's see what are the mutations which can cause primary FSGS. We already know it's a child and will have nephrotic syndrome. There are few known mutations because these are mutations of the proteins which involve the food process. The most common variant is the type 1 congenital nephrotic syndrome. I'll come to this. Okay. We have your different mutation. So you have different mutation, and this is also called as a Finnish type nephrotic syndrome. Yes, it's a bit common in Finland areas. Okay. They also have type 2 congenital nephrotic syndrome, where there's a mutation in protein called as podosin. There are multiple subtypes. There's actinin 4, there's apolipoprotein. There are multiple subtypes of nephrotic syndrome, and actinin 4 mutation can also cause. And the recent one which has been discovered is an apolipoprotein L1. Where do you see anchoring, Sajad? Can anyone add to whatever Sajad said? Anchoring is a mutation which results in, anchoring is a protein which is in RBCs and causes steatocytosis, right? So all these predominant proteins are proteins involved in the food process. So what happens is, because of these proteins, the food process cannot function. If food process cannot function, it will end up in having nephrotic syndrome and it's congenital, right? Coming back to question, Siddharth, is a mutation related disorder. I don't have any other goal apart from giving transplant at the end of the day. I'll wait for it to become completely devoid and end up in having a CKD. Then yes, the only way for me to treat is renal replacement, either a dialysis or a transplant, right? Okay, right. So these are the type etiologies of FSGS. So when I know the FSGS, like I said, it's focal segmental glomerulosclerosis. The reason why we call it is, let's assume there's a microscopy and there's a biopsy in a biopsy which is being done for the kidney. Let's assume there are 4 glomerulus. Of these, I'm going to have 2 glomerulus being destroyed. I call this a focal lesion. And of one of the third glomeruli, only half is destroyed. I call it a segmental lesion. So it's focal and segmental. It can never be uniform. It will be patchy here and there only. And it's glomerulosclerosis, right? That's why we name them focal segmental glomerulosclerosis. Like you can see, this is a microscopic finding of FSGS. You can see that I'll mark this area as 1, I'll mark this area as 2. Can I say for with confidence the second part, the lower half is definitely pink in color and sclerosed or fibrosed? That's what's happened in the FSGS. Here it's segmental. It's one half is sclerosed, one half is still normal. I'll just tell you ask you one leading question that will help me to know the symptom of this patient or the presentation of this patient. This half of the glomerulus, the lower half, which is sclerosed, do you think they'll get adequate blood supply or no blood supply? There'll be no blood supply at all, right? They cannot go inside. If they can't go inside, what do you think will happen to the glomerular filtration rate? It will reduce, right? Yes. Medico university exams tough for medium this year. See, every university has different papers, so I will not be able to comment unless you give me the paper. And I'll always say this out loud forever. Exam being tough or easy is totally based on the student. If you studied everything, any exam is going to be easy only. No, nothing is going to be out of syllabus for you guys. You will be able to do it well. So let's focus on our part, which is studying. Let's examine and decide the examiner's part, which is setting a paper. Fine. Okay, let's come back to this. So this patient will have a reduced GFR. Okay. Yes, also the patient will have nephrotic syndrome because the starting point was damage to the food process, right? So he'll have nephrotic syndrome and he'll have a reduced GFR. Okay. So this is the basis of classifying CKD based on reduced GFR. Right? So again, like I said, treatment at the end of the day, if it's going to go to a 4th or 5th stage of CKD, treatment is going to be renal replacement. A renal replacement therapy is treatment. Replacement means either dialysis or replace the kidney by transplant. Both of them comes under renal replacement therapy. Right? Okay. That's about your FSGS. So we know about two glomerular nephritis complications, RPG as well as FSGS, right? Okay, that will kind of put an end to our already known renal pathology, right? We had discussed a little bit of renal pathology yesterday, the nephrotic syndrome. We also saw a little bit of glomerular nephritis yesterday, and now we have seen about a little bit of RPG, FSGS, and also we saw about your vascular changes in the kidney, right? Now let's go to your cervical cancer. I didn't take cervical cancer. I think it was missed in the regular classes. Fine. So now let's go and have a look at cervical cancer. So that it's there. Like I said, these are a few things which I feel is difficult to cover. RCC is simple. RCC, I'm sure you know that. It's clear cell RCC, papillary RCC. We know the patterns of neoplasia. I'm sure you'll excel in that. Fine. Okay. Let's go to cervical carcinoma. Fine. Fine. Now, for any cancer or any disease for that matter, I'm going to have a template. One is etiology, second is going to be pathogenesis. I need to know the symptoms, clinical diagnosis, microscopic diagnosis, grading if any, and treatment just to cover a little bit about it. You're not going to write the in-depth about the treatment. When you come to gynecology in your final year, you will definitely be more than an expert in treating or knowing the treatment for cervical cancers. Fine, let's go to it. So I'll start with etiopathogenesis. What everyone knows the etiology of cervical cancer. Can anyone tell what is the first etiology which comes to your mind? Rather than etiology, it's a cancer, right? I will use the term risk factor. Keep this in mind. In cancers, very hardly there is an etiology, because if I call it etiology, I'm having common cold. Etiology could be viral because virus caused it. If you have the virus also, you'll have common cold. Not everyone who's having HPV will end up in having cancer. That's why I said it's put it as a risk factor, as much of a comfortable thing, right? So HPV infection, human papillomavirus infection is definitely a very important risk factor, right? Human papillomavirus can be seen in people with multiple sexual partners. Okay, one important thing you have to remember about human papillomavirus is it's not something which spreads via the fluids, bodily fluids. It spreads via skin to skin contact. So barrier contraceptive will not prevent human papillomavirus and will not be able to prevent the cervical cancer. Please do remember that, right? Okay. Again, there are few more risk factors to be written in Robbins and earlier sexual history, which means the person starts to having the sexual life starts very early. There's a very high chance that could be in multiple sexual partners. That's why it is there, right? A higher parity rate. Again, all these are just add-on factors, whatever it is there, if it's an HPV infection, and the most important thing about HPV infection is a recurrent and a long-standing infection. That's very, very important. It's not that once in a while. If I have one viral infection once in a while, it's completely fine. My body can easily take care of it. If it's a recurrent sexual exposure and a long-standing infection, there's a very high chance. And also in people with immunocompromised state. If there's a less immunity, the virus is not going to be cleared off the system. It stays there in the cervical mucosa, causes more and more and more damage, and can result in a cancer process. Right? HPV is undoubtedly one of the important etiology for or risk factor for your human papillomavirus, for cervical cancer. Apart from HPV, I can have few other environmental conditions like cigarette smoking can be there. Right? They can act as like a co-carcinogens. You can have a little bit of dietary deficiency of few things and hormonal changes. These are all contributing factors. HPV is a major one. There are few contributing factors. They are not carcinogenic alone, but along with HPV, they can increase the risk. Tobacco smoke is definitely one thing which can increase the risk. Fine. You can have hormonal changes which can definitely promote the growth of the HPV, which can increase the risk. Oral contraceptives, not to that extent, but definitely to some extent will cause a hormonal change which can increase the risk of HPV infection or will help the HPV infection sustain for a longer time. Ultimately, with cervical cancer, it's predominantly related to HPV only, right? So when you talk about pathogenesis, we have to know a little bit about HPV before jumping into the pathogenesis. In HPV, there are two different subtypes of HPV. I'm going to name them as 6 and 11, 16 and 18. Along with 16 and 18, I have many more things, 33, 35 and many more numbers. These are more important for me. Please don't forget 16 and 18. That can come in an exam because those are the most potent carcinogenic virus, cancer causing viruses, and the vaccines what we have primarily are going to target your 16 and 18, right? These are your benign serotypes. These are malignant serotypes. Okay? So why does some virus act differently and some virus act differently? A benign serotype is getting attached in episomal form. That's the reason it acts differently, and the malignant phenotypes will be integrated into human DNA. Okay? That's what will happen in your malignant phenotype. All in one entertainment, I'll come this Sunday live and tell you what will happen. I'll try to clarify all the doubts. It's so soon, I'll definitely keep you posted, fine? Okay? So the reason why 6 and 11 is causing a genital wart and why 16 and 18 is causing a cancer is it's getting integrated into human DNA. One is in the episomal form. I'll tell you what do I mean by episomal form. Let's assume this is a cell and let's assume this is a nucleus, the chromosome and the cell. So 6 and 11 genome will be here. Okay? On the other hand, if I have a cell, 16 and 18's genome will be here. Fine? That's how it will be. So that's the difference between your integrated and episomal form. So why this is important for me is, you tell me, if I have a cell division, which of these two do you think will divide? Every time there is a cell division, which of these viruses will definitely divide? 6 and 11 or 16 and 18? All in one, I didn't reply to you. Sunday we'll have a live session. I'll take care of all your questions. Integrated, right? That's the biggest problem. With every cell division which happens in the cervical mucosa, which can be hormonally stimulated, 16 and 18 every time will divide. So the proteins of 16 and 18 will always be divided and will be produced with every cell division and every cell function, right? That's why this lab less amount of HPV proteins, the oncogenic proteins, so it results in warts. But here, since it's integrated, there will be excess production of the HPV oncoproteins. I am sure you know the HPV oncoproteins. We must have read that even in your carcinoma things, right? In cancer neoplasia chapter, E6 and E7. These are two HPV oncoproteins. So E6, what they do is they will reduce or inactivate P53, and E7, what they do is they'll reduce or inactivate retinoblastoma. P3 retinoblastoma, what are they? Tumor suppressor or proto-onco? What are they? Both of them are tumor suppressor proteins, right? So if P53 as well as your retinoblastoma is getting destroyed, so can I say by default the tumor suppressor genes are gone, so they're not able to suppress the tumor formation. So this reduction will result in an uncontrolled cell division, which obviously results in a cancer. Okay, that's why I said HPV is, it's not the HPV infection which is causing the cancer, the chronicity. If I'm having HPV in the body for the next 3 years untreated, more amount of E6, E7 comes, there's more chance of having a cancer. But an acute infection came today, my body has a superb immunity, eradicates it in the next 2-3 days, it will not cause cancer. Recurrent and chronicity is more important, the longevity is more important for causing cancer compared to the infection per se, right? I hope you know the difference between what is the infection and what is infection related carcinogenesis. It's the longevity or chronicity which matters here, fine? Okay. Now we know the pathogenesis. We know the pathogenesis, we know the etiology. So obviously after pathogenesis and etiology, we need to know the clinical features or diagnosis. What do you think is the age group? For any cancer, age group is going to be an elderly person, right? Above 40-50 years and above. Presentation, symptoms. It's a tumor. Let's draw. See, this is going to be cervical mucosa. Let's say this is a uterus. Just a second. Okay, this is a uterus. In the cervix, this is cervix here. And I'm going to have a mass here. And for understanding, the vaginal area is here, right? You're going to have a mass here. This is a cervical carcinoma. Most of the cervical carcinoma, like 90% of the cervical carcinomas are squamous cell carcinoma. They are also proliferative growth. So you're going to have a growth in the cervical region. How do you think the patient will present? The very classical symptom, you see this symptom in any of your long answers, jump to the diagnosis of cervical neoplasm. It should be postcoital bleeding. Okay, postcoital bleeding is very characteristic finding of a cervical carcinoma. Postcoital, post-intercourse, there will be bleeding because there will be a trauma. There's a trauma-induced bleeding. That's a very classical finding for cervical carcinoma. This is there, definitely think of it, right? And you have to diagnose it. How do you diagnose cervical cancer? There are few ways to diagnose cervical cancer. First, for speculum examination, look at the mucosa. You have a growth, you take a biopsy, right? And also add a little bit input about the role of pap smear in case of cervical neoplasm, right? So in diagnosis, one is clinical examination based diagnosis. Like I said, I can put a speculum and look at it, right? The second one obviously is your microscopic diagnosis. In this I have two things, pap smear as well as your biopsy. So I want you to write, when you come to diagnosis of cervical cancer, I want you to put both of them, pap smear and biopsy. Now you guys are going to tell me, pap smear is diagnostic or a screening test? Pap smear undoubtedly is a screening test. It's not a diagnostic test, right? It's a screening test, it's never diagnostic. Pap smear is always screening, biopsy is always diagnostic. I want you to put this in your grey matter right now. Please don't forget at any point of time in your life, a screening test can never be diagnostic. A screening test is only screening. Biopsy is obviously diagnostic. Pap smear is definitely useful for me. I'm not denying the fact, but it's a screening test, right? Now let's see, what does pap smear give me and what does my biopsy give me? Pap smear tells me three different possibilities. You have you heard about something called a CIN? If yes, let me know. CIN 1, 2 and 3. You must have heard, right? I am not going to mention CIN now because CIN was an older classification. I don't report CIN anymore. It's always HCl and LCl. The reporting has changed. Robbins is still not changed because in undergraduate textbook. Just for you to understand that they still keep the terminology CIN. As of now, a pathologist don't report CIN and a gynecologist don't write CIN. We are automatically changed into two-tier grading system. SIL, which is low grade, squamous intraepithelial lesion, and I have something called HCl. HCl obviously stands for high grade intraepithelial lesion, and obviously I can say squamous cell carcinoma. Again, it's a screening test, not a diagnostic test, but there are pointers for me to say it is squamous cell carcinoma. Biopsy is any day diagnostic. I'll tell you what is LCl means, HCl means, and how do I correlate with CAN. Fine. Okay, Asma, this is a FARRE class. This is for a student who is going to the university exam very soon. Basics we'll learn in the university classes, fine? Okay. Now here, so we have LCl and we have HCl LCL is equivalent to the older CAN1. HCl is equivalent to the older CAN2 and CAN3. That's a difference here. It's CAN2 and 3 will be HCl, CAN1 is LCL, the older ones. If I take biopsy wise, you'll have lower 1/3 dysplasia. Okay, that's CAN1 or LCL. And when I say dysplasia, we already know the features of dysplasia: pleomorphism, high NC ratio, loss of polarity, mitosis. That's true for every dysplasia throughout the body. Fine. When I take HCl, like I said, I divide it into two parts: CAN2 and CIN3. The other name for CIN3 is CIS. Can anyone tell me what does CIS mean or what does IS mean? In CIN2, I have 2/3 dysplasia. Previously it was lower 1/3, here 2/3 dysplasia. I'll call it CIN2. And here it will be full thickness dysplasia. Okay. CA stands for perfect sheath, carcinoma in situ, right? Or a full thickness dysplasia, or CIS, it is in situ. It is not yet breached, it is sitting inside the epithelium only. That's carcinoma in situ. Great, Sudhir, right? Okay, that was the classification here, CA and CAS, right? So this both of them now I call it HCl. I'll tell you why we have changed the rationale is it's very difficult for a gynecologist to treat CA2. We don't know what to do. If it's too tired, now LCL, low grade, conservative management, HCl, high grade, surgical management. It's very simple to treat. That's why we got from 3 tier to 2 tier grading system. This is how the entire world is reporting. I want you to focus on this, especially in the Viva. In the theory exam, write both, but it's fine. But don't write just CAN alone, because CAN is an old terminology which has been gone. Fine? Okay. Now, we'll take carcinoma cervix. So let's take carcinoma cervix. Like I said, 95% and above of them are squamous cell carcinoma only. Because the ectocervix is squamous epithelium. Right? So for any squamous cell carcinoma, in microscopy I'll have the same finding. You'll have the 4 features of dysplasia. I'm not going to repeat them, we already know from our classes. It's your pleomorphism, high NC ratio, mitosis, loss of polarity. It's a squamous cell. So obviously you'll have keratin pearl. Keratin pearl is your pattern for squamous cell carcinoma, and obviously you'll have invasion. So invasion present, I call it a cancer. That's why biopsy is always diagnostic. FNA is a cytological procedure where I cannot appreciate invasion for diagnosis, right? If at all immunohistochemistry is asked or required, there are 2 markers, P40 and P63. Both of them are good markers. P40 I would say is a better marker than P63, but both are equally good. Both, anything you can apply to say it's a squamous origin, right? Okay. So you must have seen an image from Robbins. A real image, biopsy image is a pictorial representation. Let's assume this is normal. Now if you look at this image, can I say in this below 1/3, can I say it's become darker here? It's become darker? Yes or no? It does. The nucleus has become a little bit bigger, it's become a little bit bluer, right? So can I say here 2/3 have become darker? Yes. And here it's full thickness. And here it is invading. This is my basement membrane, right? This is a basement membrane, it's invading. Okay, so if you are writing a cervical cancer question, if you can represent this in an exam hall, that will be amazing, because this gives an entire screenshot of what happens. So you can also write here, this is LCL, this is HCL. If you want to write the older one, this is CAN1. Again, for understanding, this is completely normal. This part is CAN2. Till this is CAN2. The next part is CAN3. In both the classification old and new, whenever you see invasion, I'm going to call it a carcinoma. Fine. So that's a range. That's how the grading happens in case of cervical carcinoma. And you have to know about LCL, HCL as well as squamous cell carcinoma. Fine. We know this part. So we know both the etiology, pathogenesis, the role of pap smear. Like I said, pap smear is a screening test. It's not a diagnostic tool. It's only a screening tool. It can never be useful for diagnosis. Fine. And you also know about cervical cancers as well. Fine. Just give me a second. Okay, fine. Now let's go to one more new topic here, endometriosis, right? let's see what we see in endometriosis, and let's try to cover a little bit about endometriosis. Okay. So what do you understand better about endometriosis? We know a little bit about cervical cancer. We look at endometriosis. So endometriosis, by definition, it's nothing but the endometrial tissue outside the endometrial cavity. I call it endometriosis. That's all right. When the tissue goes outside the endometrial cavity, we call it simple endometriosis. Fine. It's not just the endometrium; it's endometrial gland plus its stroma. It's going to be seen outside the endometrial cavity. We call it endometriosis. It should be seen entirely outside the endometrial cavity. That's why we call it endometriosis. Fine. Okay. So it's an endometrial tissue going outside. So there should be some way or pathogens or theories of endometriosis. There are multiple theories of endometriosis. Can anyone tell me a few common theories which comes to your mind? Whatever comes to your mind, how do you think an endometrial tissue can go outside? Just a random question. There should be some root, right? Only then can go outside, right? It's a very common thing which can happen during the reproductive age of the women, because it can easily go outside, right? So that's the most common accepted theory is regurgitation theory. Okay, regurgitation theory is one of the most common accepted theory for endometriosis. So what it says, it's reverse flow of menstrual fluid. It's regurgitant flow, that's all. So I have an uterine thing like here. The normal flow is like this. So if it goes back, it can go to the fallopian tubule, it can go to the ovary, it can go to the entire peritoneal cavity. Right? That's definitely a possibility. It can definitely happen. Gaurav, I'll tell you, I'll come live this Sunday and definitely learn about it. Fine? Yes, Tanmay, what happens? Okay, so here the reverse flow can easily explain the most common site of endometriosis, which is ovary, which can easily explain how it can reach a fallopian tube, which can also easily explain how a tissue can reach your peritoneal cavity. Yes, definitely it can explain. But can it explain how it can reach the lung parenchyma? It cannot. Can it explain how it can reach the bone? It cannot, right? So there is possibilities it can explain, some of them it cannot explain. So we had something called the coelomic metaplastic theory. So metaplastic theory is the entire coelom, there's a metaplasia, that's all, a coelomic epithelium. The pelvis epithelium becomes mesothelium, becomes an endometriotic tissue. It can happen, right? It's metaplastic theory, right? So here the pelvic peritoneum is kind of becoming an endometrial tissue. It's a metaplasia, right? That's what I say, coelomic metaplastic theory. The third part, there are few places which say that there's a metastatic theory. Okay? So when I say metastatic theory, like a metastatic tissue or a cancer tissue, a normal endometrial tissue during menstruation can break and go into the blood vessel. It can reach the distant sites. A metastatic theory, a benign metastatic theory, will easily explain how it reaches your lung parenchyma, how it reaches your bone parenchyma, and also how it can reach the brain tissue, right? Gaurav, like I said, I'll come live on Sunday. We'll clarify all your queries, when we are going to start and how to proceed and everything else, fine? Okay, so these are few theories which are very confidently accepted one. Please don't forget regurgitant theory, because that explains how most common site of endometriosis is being taken care of, right? That's one part, right? Now, coming to the second thing. So obviously I know the theories of endometriosis. The next thing for me is that molecular studies, because molecular studies have become of late very important, because we have found that endometriosis can be one of the risk factors for endometrial carcinoma of the ovaries, right? That's one of the risk factors. Ovarian endometriosis is a risk factor, which means it's not just a tissue going and staying there. Something is happening, molecular change is happening, right? There is a little bit of release of or more function of pro-inflammatory cytokines. This is happening. Whenever there's more pro-inflammatory proteins, inflammation, there's definitely high great chance of having a mutation because of reactive host species, right? You'll have excess deposits of interleukin 6, interleukin 8, tumor necrosis factor. That's why the pain associated with endometriosis will be taken care of by NSAIDs, because it's inflammation related pain most likely, right? And we also found that this endometriotic tissue, it's a functional tissue. Even if it's ovary, it's going to be functional. It will have more estrogen production than a normal tissue, right? There's going to be an excess of estrogen production by the stromal cells than a normal endometrial tissue inside the uterus. That's also a problem for me because whenever there's more and more amount of estrogen, what will estrogen do? Will estrogen cause proliferation? Definitely it will cause proliferation, right? At the same time, we have also found that there are few mutations which will be seen as well. Mutations like PTEN, which is commonly seen, and you have one more mutation called as ARID1A. Right? These are two mutations which are seen in endometriotic tissue. Right? So this is the reason we said that this could be a precursor for endometriotic carcinoma of ovary. We have endometrioid carcinoma of ovary. So we know that it's not just a benign tissue, it's going there causing inflammation, causing mutation. So it's not just a benign deposit, it has a long-term complication. It has to be taken care of it very well, right? So these are the places where it can happen, right? So we know the pathogenesis, how it reached and how it's sustaining. The sustaining is because of these mutations in the growth factor, they are still growing there, right? So now clinical features and diagnosis. It's a functional endometrial tissue outside the uterus. So will they also have the same proliferative phase, secretory phase and menstrual phase? Yes, it will happen. So there will be shedding of endometrial tissue in the ovary. Will it pain? Obviously, right? So it will have cyclical pains. Cyclical menstrual pains. Extremely cyclical menstrual pain in whichever part of the body is. An extremely severe abdomen pain. That's a very likely chance it could be because of that, right? Okay. Right, that's a common thing. Cyclical menstrual pain in the abdomen suggests of endometriosis. Rarely endometriosis can be associated with little bit of infertility also, but this is the most common thing. Cyclical menstrual pain, abdomen pain is an abdomen, can be in the chest if it's lung, or bone if it's bone, or colonic. It can be based on the site. If it's a colonic endometriosis, see, colon can also have endometriosis. Here you have dysentery because you have blood loss in the colon. You won't think of it